charged to talk about Africa, and that's a large continent and very heterogeneous. So all I want to do is locate within South Africa and give some more details on the treatment as prevention trial that Brigitte Bazin introduced yesterday. If I can manage to move here. Yeah. So essentially, of course, the HIV epidemic is in its most severest in sub-Saharan Africa, with about 90% of new infections estimated to occur in that region and 10% in the rest of the world. And South Africa is, of course, the country with currently the largest number of people alive who are HIV positive and on ART. The first number, 6 million, the second number, 1 million, shows the extent of the epidemic in a country of 50 million people. And KwaZulu-Natal within South Africa is the province with the highest antenatal HIV prevalence for many years consistently and highest HIV incidence. And there's no evidence for declining incidence, neither from population-based studies as ours or from studies such as the large and well-conducted clinical trials that Gita Ramji or Slim Karim are conducting in the same area. The Africa Center for Health and Population Studies, where this treatment as prevention trial will take place, is located in Klabisa subdistrict of KwaZulu-Natal, which covers about 40%, or the Africa Center demographic and health surveillance area with an ongoing HIV surveillance and demographic surveillance covers about 40% of that population. And of course, the significance of a treatment as prevention trial is that there is increasing evidence from observational studies and from mathematical modeling that treatment as prevention can work, but we do need a clinical control trial, or a control trial rather, in a hyper-endemic setting in sub-Saharan Africa. And the Africa Center community, or this area where the Africa Center is active, is a very good setting for such a trial, partially because of the sad fact that HIV incidence is extremely high and has remained high and is not declining. Here is the overview of the sex-age pattern of HIV incidence at the Africa Center from 2003 to 2010, based on 50,000 person-years of observation and 1,500 longitudinally observed seroconverters. And we see these extreme HIV incidence rates in women peaking at age about 25, in women at 7 per 100 person-years, and in men at about 5 per 100 person-years at age 30. The ART coverage in this area is probably higher than the South African overall estimated coverage, which is currently estimated to be about 50%. We have here some preliminary findings, which a colleague of mine, Abraham Malaza, will present at the South African AIDS conference, where we took a random sample of the individuals in the Africa Center health and demographic surveillance areas and tested for CD4 count and find essentially, when our numerator is people on treatment, we can link those who are on treatment in the surveillance area into the population base. And if we then have a numerator, those on treatment who would have been eligible to participate in CD4 count testing, as a denominator, all those on treatment, plus all those not on treatment with CD4 counts below 200, we find an ART coverage at the current South African guidelines of about 3/4. If we think forward for treatment as prevention, this coverage would be, of course, relative to everybody who is HIV infected, and would constitute about 1/3 of people currently covered. So we would need to find effectiveness in covering the additional 2/3 who currently do not utilize ART. And in starting a treatment as prevention trial, of course, the main hypothesis is that HIV testing, hopefully of all members of a community, followed by immediate ART initiation in hopefully a very large proportion of those testing positives, we can prevent onward transmission and HIV incidence. But in addition to the primary outcome, which is longitudinal population-based HIV incidence here for this trial, we are of course also very interested, and Brigitte yesterday already talked about the treatment as prevention trial and gave some details, and I'm expanding here in a sense as partner and implementer of TASP. We are, of course, very interested in the health systems and health services outcomes of TASP, enrollment on ART, in those eligible to enroll, ART retention and adherence. Then we are very interested in the secondary outcomes on health, mortality, morbidity. What are the effects of TASP on incidence of ART side effects, of adverse events, and of TB incidents? Regarding the economic and downstream effects of TASP, we are of course concerned about financial sustainability, operational sustainability, but also the productivity effects of putting such a large proportion of people who otherwise would not need to be on treatment. What does it mean regarding productivity lost and quality of life? So I could imagine that quality of life is reduced due to ART side effects and adverse events. On the other hand, I could also imagine very plausibly that quality of life is actually enhanced. And we find in our preparatory study here that people, when we ask them, are very aware that the South African guidelines of initiating below 200 are far below the developed world standard and are complaining about it. And so far, our acceptability surveys have shown that people are keen on a task because it means that they're moving towards the developed world standard in being able to access ART. And then finally, of course, behavior. We would be concerned about risk compensation, so we will look at the behavioral impacts of TASP. The PIs, as Brigitte mentioned yesterday, are Marie-Louise Nouvelle and François Dabi. It is cut into two phases. A first phase, which we are embarking on this year as a proof of principle, where we randomize 4 clusters initially of a total of 32 clusters to see can we achieve high testing rates and high enrollment on ART of HIV positive people in this area, and have longitudinal follow-up of the entire cluster community, HIV positives and negatives, of course, in order to be able to measure our outcome longitudinally measured incidence. And we are here mainly interested in ART enrollment, adherence, and uptake. The second phase then, which will pool in these initial 4 communities, will expand the trial to a total of 32 communities. And that's my last chart, which is essentially, again, what Brigitte showed yesterday, a mock randomization to show where we would conduct this trial and how the trial design would look in one instance. And in the power calculation, the trial is powered to detect a 30% reduction in HIV incidence. We have, of course, incorporated imperfect participation, migration, contamination. People can have sex outside their cluster communities, and ART and adherence that is imperfect. And we think we have done so conservatively because we've measured these parameters for the last 10 years, so we know what the situation is in this area. Thank you.